Dear Chairman, dear ladies and gentlemen, first of all, I want to thank Stefano, Della Villa, Gianni Nanni, Brian English, Mike Davison, and the entire Isokinetic Society for the invitation to speak here. It's a big honor for me to talk about my experience in muscle injuries and to talk about the development of diagnostic and therapy of muscle injuries during the last 30, 40 years. Since 1975, I'm responsible for the medical care of professional football players in the first Bundesliga in Germany from 1975 to 1977 for the team of Hertha BSC Berlin, and since 1977 for the FC Bayern Munich team. During the 70s and even in the 80s, and somehow until today, if we are honest, muscle injuries were not really treated in a differentiated way. They were only quantitatively, that means by size, but not qualitatively distinguished. It was simply adopted a gradual difference in the severity of the injury. Imagine in the 70s and the 80s, there was absolutely no imaging available to diagnose muscle injuries. There was no ultrasound or only images with very bad quality. There was no MRI. Therefore, I had to train myself in clinical examination, especially palpation of muscles, to better understand the injuries. In diagnosis of a muscle injury, we had to rely on our own clinical findings only. Therapeutic concepts were missing. Initially, heat treatments were prescribed for fresh muscle injuries. Sometimes even plaster casts or hot springs were recommended. Before then, ice water and compression as adequate immediate treatment was used. All possible therapies were used rather experimentally. However, at that time, real guidelines for the treatment of muscle injuries were missing. No rehabilitation plan was recommended to the player. Finally, after weeks of no sportive activity, the athlete was asked about his complaints. Frequently, it was said, just try it, maybe it already works out. So I talked about the 70s. I saw these cases in the 70s and 80s. Recurrences were and are still frequent. The literature says that the recurrence rate for hamstring injuries in sports is up to 30%. I made muscle injuries to my main interest. I trained myself more and more in clinical examination, especially palpation, which was not taught during the years of residency when becoming specialized in the field of orthopedics and sport medicine. Based on clinical findings and medical history, I found different injury types. In the mid-80s it was. I then presented my differentiation of muscle injuries at the German Sports Medicine Congress in Berlin for the first time. Great resistance and doubts from the colleagues and scientific audience was the reaction. I was convinced that there was a fundamental differentiation. On the one hand, muscle injuries without, and on the other hand, muscle injuries with a structural tear. At that time, my impression and theoretical consideration were that most non-structural injuries are neuromuscular disorders, not in a neurological meaning, but in the meaning that there must be a dysregulation in the innervation of the muscle. We name these injuries today functional or non-structural injuries. However, these terms were not used yet. Structural as well as non-structural injuries prevent the player from sportive activity. But they have different treatment pathways and different layoff times. Since layoff time plays a crucial role in professional sports, especially in football, where return to play has a significant financial and strategic consequence for the player, the team, and the club, the categorization of muscle injuries is of high interest. Only because of the differentiated approach, the treatment period for the minor structural muscle injuries could be reduced to 10 to 14 days, and for functional injuries to 3 to 5 days. According to the medical history and the findings on palpation, we find in most structural injuries a fine needle-like up to knife-like sharp pain. On palpation, a fiber disruption can be detected. Logically, this is much easier in more severe injuries. Palpation in the region of the injury is painful. These injuries are more likely localized on the muscle-tendon junction. In most functional injuries, there is a cramp-like pain, which usually develops over several steps. The pain is not acute. During palpation, there is neither a muscle tissue gap nor a hematoma to be found. The muscle tone is increased in a spindle-shaped, edematous, swollen muscle section around about 15 centimeters. Functional injuries are more likely within the muscle belly. Maybe I have to explain here how we examine a muscle injury. Many experts, like Professor Ekstrand and others, have published that clinical examination is the most important step in diagnosis of a muscle injury. Imaging like MRI or ultrasound are used to provide additional information in order to confirm the diagnosis. After medical history, a careful clinical examination of the injured area with inspection, palpation, comparison to the contralateral side, and functional testing of the muscles is crucial in the diagnosis of a muscle injury. Palpation gives the examining physician an impression of the affected muscles in comparison to the muscles on the non-injured contralateral side. Palpating a muscle provides the tone, the temperature, the condition of the muscle, and possible adhesions, scarrings, and so on, which is essential for the diagnosis. These are qualities that imaging never can provide. Palpation reveals if there's any pressure pain and whether the pain is localized or whether it covers a large area. It also helps to detect if the muscle is edematous, whether there is pain or relief on careful stretching, and if there is a palpable defect. The hand and fingers slide several times over the muscles, getting an impression of the muscle tone and searching for a muscle area that has a higher tone than the adjacent muscle. Usually a tear can be found within a firm muscle band. Palpation is performed with moderate pressure and movements. The fingers should repeatedly slide on the muscle from proximal to distal and back, as well as across the fibers, and should not press only the muscle down. In the early 90s, after I had some training in palpation since about 15 years, I made the following experience. I palpated in a particular type of functional injuries, a thin accompanying edema in the periphery of the injured muscle cord, which is hypertone all over its total length. This edema was not found in other types of functional injuries. Signs of inflammation, crepitation, or hematoma could not be found. I realized that lumbar problems, such as disc bulging, degenerative changes, or only blocked joints in the lumbar spine or blocked SIG, can have a decisive influence on the muscle tone regulation and play therefore a crucial role in case of muscle tightness due to an irritation of the motor nerves. We see quite often that athletes have not realized their lumbar problems because they do not feel pain in the lumbar spine. A dysregulation of the lymphatic system and a subsequent muscle edema is thinkable since the regulating vegetative nerve fibers that accompany the motoric nerve are also affected. Today, we name this particular functional muscle problem spine-related neuromuscular disorder. It could be argued that this presents mainly a back problem with a secondary muscle disorder. However, this secondary muscle disorder can prevent a player from training and competition and will require comprehensive treatment that addresses the primary lumbar problem as well, facilitating the athlete return to sport. Thus, a differentiation of these disorders from others is important, not only because of the different pathogenesis, but more important because of different therapeutic implications, which means that we have to treat the lumbar and the iliosacal problems. After an infiltration treatment of the lumbar spine, quite often a spontaneous tonus decrease in the corresponding firm muscle can be observed. In case of a spine-related muscle tightness, the athlete feels a spontaneous relief. I have tried to explain these findings in presentations and publications since the early 90s, but it took time until the content has been understood. The today's findings in high-resolution imaging, as well as the today's physiological theories, support my ideas that were initially made ridiculous by the scientific world. Therefore, I'm grateful that we can find more and more scientific work in muscle injuries. In the late 90s and beginning of the 21st century, more and more research was done on muscles. Many famous researchers did fantastic studies on muscle biology, biomechanics, regeneration, and preventive strategies. Just to name some of them in alphabetical order: Karl Askling, Tom Best, Jiří Dvořák, Jan Ekstrand, Bill Garrett, Tero Järvinen, John Orchard, Shai, and Daniel Gary. We started to understand the pathobiology of muscle injury, the different injury phases, the regeneration, the remodeling, the rehabilitation, as well as the need for early mobilization. It is the merit of the outstanding UEFA injury study organized by Professor Ekstrand and his fantastic team that muscle injuries have been evaluated for the first time in a professional, structured way. The immense collected and every year growing epidemiological data have demonstrated the importance of these injuries in football, but also show how heterogeneous muscle injuries are assessed and treated until today. In case of a structural injury, every minute counts, because hematoma will displace muscle fibers and will delay later healing. With optimal initial treatment, the risk of adhesion and scar forming is substantially reduced. The immediate treatment is highly effective and not questionable. It should follow the RICE principle: rest, ice, compression, and elevation. Namely, a compression applied as soon as possible after the injury, combined with ice water applications, reduces hematoma formation as well as a subsequent inflammatory response. I have made the experience that an infiltration treatment can influence the healing process dramatically. The aim of infiltrating therapeutical agents direct into the affected or injured muscle tissue is twofold: to regulate the muscle tone by preventing a reactive increase in tone, or by relieving muscle firmness that is already present, and to create optimum conditions for muscle regeneration. In case of a functional disorder, a specific treatment pathway has to be chosen. A spine-related problem will be only solved with a specific treatment on the lumbar spine. That means specific physiotherapy, core exercises, infiltration treatments. On the other side, a fatigue-induced muscle problem could be easily treated by break and massage. I have changed my therapeutic approach only marginally since the 70s, since it has been proven highly effective. It is necessary that the therapist is able to localize the injury by palpation to set the infiltration needles precisely. Since the 70s, I use activigene together with Tromel in the treatment of muscle injuries. Activigene is a deproteinized hemoderivat obtained by ultrafiltration of calf blood. It is constituted mostly of electrolytes, essential trace elements, a mixture of amino acids, and intermediary products of carbohydrates. I know that there is still controversy about its biologic actions, especially in muscle tissue. But I'm still convinced that activigene is the most helpful and highly effective medicine in our treatment. The daily experience with athletic muscle injuries, some of them were treated not successfully elsewhere, supports this. In over 36 years, I have never experienced any side effects. No complication occurred. The first insight in the mode of action were that activigene promotes an insulin-like activity of the local cellular energy metabolism through a better supply of muscle cells with glucose. That means that activigene improves the uptake and the utilization of glucose. Besides this, it improves the blood circulation. That was the reason for me to use it in order to improve and accelerate the healing of muscle injuries. Today, we have some more reliable findings. Preliminary data show that activigene upregulates significantly muscle-specific genes that promote muscle healing, and that means the regeneration of muscle fibers. So after some weeks, we do not find any scar. It's a muscle regeneration clearly. Autologous serum products have lately become a focus of growing interest in the treatment of muscle and tendon injuries. PRP is increasingly used in situations that required rapid return to play, and more team doctors report subjective data of positive effects in muscle injuries. However, I doubt that PRP will help to improve muscle healing. In contrary, it can lead to formation of scar tissue due to its effect on fibroblasts. Adequate physical therapy methods have an important role. Continuous and intensive physical therapy as early as possible, rehabilitative exercises, and training therapy are essential components in the reconditioning of an injured structure. The restoration of coordination and proprioception, the normalization of movement patterns, the prevention of muscle atrophy, and the recovery of normal force development. A precise rehab plan has to be developed for every athletic muscle injury, including recommendation for sport-specific training with increasing intensity. With this procedure and thorough follow-up examinations, low recurrence rates can be achieved. In athletes with more severe muscle injuries, it is particularly important to conduct regular clinical examinations to evaluate the progress of healing. With the best possible treatment and discipline of the injured person, the absence time in a functional muscle injury is less than a week, in a minor partial muscle tear 10 to 14 days, in a moderate partial muscle tear approximately 6 weeks, and in a severe tear up to 12 weeks. The vast majority of all muscle injuries heals with conservative treatment. Surgery is very rare and only necessary in total tendinous avulsions with a retraction of the tendon of more than 2 centimeters. Non-steroidal anti-inflammatory drugs should not be used in muscle injuries since they can have even contrary or negative effects on the healing process. Moreover, they suppress pain perception, but this is counterproductive because perception of the injured muscle by the athlete is of great importance during the course of rapid or progressive rehabilitation. Steroids should definitely not be used. They can retard healing and increase the risk of a soft tissue infection or necrosis. In the past years, our work got increasing attention from the scientific world because we combined our many years of development in the diagnosis and treatment of muscle injuries with studies and scientific structured work. Our textbook for sports medicine, which is finally available in English now, has already attracted considerable interest. This reflects a new comprehensive and consensus-based classification system about which Dr. Übelacker will talk in the following presentation. I hope that the technology and sensitivity of MRI to detect muscle injuries may evolve. In some years, I hope that it may be possible to better visualize tears and other pathologic changes within the muscle. This should further improve the ability to undertake effective interpretation and diagnosis. Currently, MRI is not suitable to provide the correct diagnosis for functional injuries, and even in structural injuries, there are limitations for MRI. For example, it is often difficult to detect the real size of a muscle tear due to limited resolution and preciseness of the images. Too often, the size of the hematoma influences the assessment, and the real structural defect of muscle tissue cannot be differentiated within the bright signal of the MRI. I'm convinced that after a decade of bone and joint science and thousands of meetings on surgery of ligaments, bones, joints, and other operative issues, there is high time to be more concerned of muscle injuries. I'm grateful to be a part of this conference where muscle and tendon is the issue. I hope that this is one of the platforms where new scientific work on muscle injuries should be planned in order to better understand these interesting injuries. Thank you for your attention.